Good evening, everyone. Thank you so much for joining us tonight for our latest Medicine for Members event. For those of you who are new to these events, these are organized and shared by Council of Governors. My name is Sneha Bedi. I'm a Royal Free London elected patient governor and the lead governor for the Council of Governors. Our Medicine for Members events focus on the topic that we know are important to you and our members. They give you the opportunity to hear more about the Royal Free London services. During tonight's event, you will hear from our expert clinicians about how we are encouraging the staff, patient, and the public to stay healthy and avoid illnesses. Our topic tonight is building healthier communities. It is predicted that more than 9 million people in England will be living with major illnesses such as cancer, diabetes, and kidney diseases by 2040. This is an increase of 2.5 million people compared to 2019. Improving the health and well-being of the community that we serve is at the heart of the Royal Free London's 5 years clinical vision. Our dedicated population health team is working beyond our hospital sites, helping to prevent diseases and reduce health inequalities and bringing the best of the NHS to all our patients. This evening, you'll hear from Dr. Judith Stanton, Director of Population Health, Dr. Ala Jawad, Consultant in Population Health, Dr. Maria Goddard, Active Hospital Lead and Lifestyle Physician. Judith will also share her experience of being diagnosed with breast cancer and how taking care of her health and well-being made a real difference to her recovery. Thank you, Judith, for agreeing to share that. Before I hand over to our presenters, there are just a few housekeeping points that I would like you to be aware of. To ensure that the event runs smoothly, you are set up to view only. This means your camera has been disabled and you have been put on mute. If anyone experiences any connection or visual problems, a recording will be sent to you in coming days. If anyone has joined us this evening and is not a member, you can sign up on our website. The link is in the chat now. There will be a Q&A session for our speakers after they have presented. We have received several questions ahead and we will try and answer those. And for you who are attending, please use the Q&A function and on the right-hand side and ask any questions that you may have. We will try and our best to answer all the questions that you might have asked, but in case we run short of time, we will try and address those questions through email. Our speakers won't be able to answer any specific or personal questions for your care or your treatment, so we will have to skip those questions because of privacy issues. If you would like to contact the Council of Governors with any queries, concerns, or comment, please do so via the Governor's inbox, which is on your screen now. I hope you enjoy the event, and I will hand over to our first speaker, Dr. Judith Stanton.
Thank you very much, and lovely to be here. Thank you so much for the invitation to me and my team. Next slide, please. So population health, an introduction to population health. Who are our population? Well, and what do we look like? We see about 1.5 million patients a year. We have 12,000 staff. We work over 70 sites across North London and Hertfordshire. So if I was to think about one word to describe our population, I think I'd use the word diverse. We're diverse in age, in ethnicity, in deprivation. And this slide just gives a bit of an example of that. So more than half of our inpatients have an ethnic background other than white British. Barnet's got the largest population of older people in London. 1 in 5 adults in Camden binge drinks. 1 in 2 people in North Central London is overweight or obese. And we have marked inequalities in life expectancy, healthy life expectancy, and health inequalities by deprivation across North Central London. And if you look at the stats on the far right of this chart, this slide shows that we've got a 12-year difference in life expectancy for men and women if we look at between the most deprived and the least deprived wards in North Central London. And the vast majority of this difference in life expectancy is because of the long-term conditions of cancer, cardiovascular disease, and renal disease. Next slide, please. So let me try and make this a bit real. By 2040, 1 person is going to be diagnosed with cancer every minute in the UK. This is really real, and the numbers are huge. Cardiovascular disease remains one of the leading causes of disease and death in the UK and in North London. And more than 9 million people in England are projected to be living with one of these major illnesses by 2040. And that's a huge increase because in 2019, it's increased 2.5 million people since 2019. So I sometimes describe this as a tsunami of these cases coming down the line. And yet we can really do something to make a difference here. And this is what's influenced our new clinical strategy. So if I could have the next slide, please. So this is the clinical vision for the Royal Free Group, and as you may know, we are planning to merge with North Mid in January. So each of our 4 hospitals is in a different borough with a different demographic profile. The population looks a bit different, and so each of our local hospitals has got a local priority to meet the needs of its population. And we also have group-wide priorities for all the hospitals, and these are cancer, cardiovascular disease, and organ failure and transplantation. So that's liver failure, kidney failure. This is what we can do in our hospital, but we also are very clearly playing a role to improve the health of our population, to reduce health inequalities, and to do this through our tripartite mission of excellence in clinical care, excellence in education, and excellence in research. And by doing this in partnership, because this is what we can do in the health service, but that's just a whole part of the picture. So if I could take us to the next slide, please, I'll show you what our approach to population health looks like at the Royal Free Group. So we define population health as our approach to improve physical and mental health outcomes, promote well-being, and reduce health inequalities across the entire population, both within and outside the hospital walls. And we do this in sort of a 4-pillar approach. So one is looking at what we call the wider determinants of health. This is everything that's outside the health service. So when we've merged with North Mid, we're going to have we will employ 16,000 staff. We will be the single biggest employer in North Central London, which means we've got a real opportunity to help improve the health of our population by being a good employer. Being in good employment is good for health. By thinking about our commitment to the green agenda and being aware of how we can minimise our impact on the climate and being very careful about our sustainability, our use of our estates. So we've got these wider determinants of health where we play a very key role as what's called an anchor institute. We also work in an integrated fashion across the health and care system. We've got a large number of strategies I've outlined here that show how we do that. And included in that is our clinical practice groups, which are set up to make sure that we reduce unwarranted variation. We have a very key role as a good partner in the places and the communities that we live in, and we have a key role in our borough partnerships, and we have a key role being a good partner across the whole ICS, across the whole integrated care system and the integrated care board. But more of the talk tonight is going to be about the health, behaviour and lifestyles, the fourth quadrant in this circle, if you like. We've recently launched our Faculty of Population Health, and we're going to talk a bit more about that later on this evening, and looking at the influence and the impact of lifestyles, including we've got NHS long-term plan tobacco dependency advisors to help support people quit smoking within the walls of the hospital. So next slide, please. When I talk about population health, I talk about a normal distribution curve or a bell curve, and I wanted to just give a minute to describing this. So here we have a normal distribution curve of whatever it is, so low, normal, and high risk of, say, risk of cancer. And if we take a population health curve, a population health approach, what we do is we shift that curve a little bit to the left. So as an individual patient, we might not notice much difference, but at a population level, it's a huge impact. And it's embedding prevention for the whole population that's going to just turn off the tap a bit to reduce the size of the tsunami of cancer cases and cardiovascular disease cases that are otherwise modelled to be coming down the line. And we've shared those figures that are projected at 2040 already with you this evening. If you look at the high risk category at the far right of the curve, this is where we have much greater interventions with high risk patients, where it's more obvious what we're doing with a patient to improve their health. And that makes a huge difference to that patient in that moment. But actually, what we want to do is improve the health of the whole population and reduce health inequalities. We need to be thinking about that whole population and shifting the curve to the left. And I say it will reduce health inequalities because our patients are sick, and therefore already have some diseases. And we have a real opportunity, whatever they come into the hospital with, to make sure we're optimizing their chances of a healthy or healthier life as possible in their interactions with us, what we call teachable moments. Let me try and make this tangible for you. Next slide, please. This is alcohol. So we employ 12,000 staff. If every member of staff had one conversation once a month, brief advice, takes a minute or two, that would about alcohol, that would be 144,000 interactions. We know that alcohol brief advice changes the drinking behaviour of 1 in 8 people, and that means that every year 18,000 people would reduce their weekly alcohol intake by 4 to 5 units. That's by each member of staff having one conversation a month. So you can see how that really impacts on shifting that normal distribution curve, that population bell curve, a little bit to the left. The interaction is one conversation once a month. So it's an almost intangible interaction. If you think about the patients in the high risk category, we have an alcohol care team, a brilliant team. So they're working at the high risk end of the curve. But actually, that one conversation once a month, that will have a massive impact on the health of our population, on the and on the system pressure within the NHS. Next slide, please. So that's what it means at a population level. Next slide, please, at alcohol. Here's smoking. I just wanted to demonstrate that actually some of this stuff is really beneficial really quickly to individuals too. So we all know that smoking is bad for our health. We know that it's the biggest cause of if we could quit smoking, we would reduce the biggest cause of morbidity and mortality in our population. If we quit, we will see benefits after 20 minutes. Your pulse rate will already come down. After 48 hours, there will be no more carbon monoxide in the system. After 72 hours, breathing feels easier. This is really quick stuff. After 1 year, the risk of a heart attack is halved. This is real, this is tangible, it's actually very quick, and we know what to do and we know how to do it. Next slide, please. So NICE, National Institute of Health and Care Excellence, came out with behaviour change in 2014, so it's a decade ago. Individual approaches, how to embed healthy conversations, making every contact count, how to embed prevention in our interactions, in those teachable moments when we're seeing our patients. We don't routinely do it, and we're absolutely not alone as a hospital, and we're absolutely not alone in GP surgeries. It's not part of our cultural norm to do this routinely, and yet we know that it helps not just the patients but staff as well. The paper on the right hand side is a paper in the Journal of Public Health from the Royal Free. When we did a pilot here a few years ago, and it demonstrated that not only was taking this approach universally and comprehensively and systematically good for patients, but it also improved staff lifestyle, and it improved the lifestyle of staff's families as well. And yet, hard to sustain in a busy and stressful work environment. I absolutely get that, but the size of the prize is so fantastic that that's why I put in a bid to the Royal Free Charity to fund the Faculty of Population Health, and an enormous gratitude to the charity for funding us. The faculty will tell you more about soon, but it's a staff education and training program to lead culture change, to embed prevention as business as usual in everything that we do. So I knew this when I put in the bid for the charity. I put in the bid on a Friday, and then on the Monday, I started my cancer treatment as a patient at the Royal Free. Next slide, please. Here's what I learned as a patient. I learned that I have so much to thank my colleagues and my trust for. I also learned this, that my variables were put into this tool. I imagine every NHS trust uses a similar tool for patients with breast cancer. It gives you a very personalized response. So my variables about everything about my age and the staging and so on got put into this, and the answer came out: take these drugs. And I take the drugs, and it increases my chances of survival by 5%. But what I also discovered was that once I had breast cancer, I increased my chances of survival by 40%. 40% by being physically active. And I'm incredibly grateful to Maria, whom you'll meet later on this evening, who is our active hospital lead, and I'm lucky enough that she's in my team. So during the 8 months of my cancer treatment, when I knew I needed to be more physically active, but I didn't know how at different points of my treatment journey, Maria and I would have a WhatsApp conversation, and she would say, okay, do this and do this and do that. And so I've been able to maintain my levels of physical activity throughout to increase my chances of survival. And as opposed to drugs, which give me a 5% survival. And I'm just trying to make this real. I'm trying to make this tangible, because this stuff is really important. The size of the prize is huge. And I've mentioned that in our publication, it not only benefited the patients, but it benefited the staff, and it benefited the staff's families. I also tweaked my diet a bit, not a lot, but I tweaked it a bit once I got my diagnosis. Obviously has been good for me, but it's reversed my husband's pre-diabetes and it's lowered his cholesterol. So you can see how these benefit at an individual level, at a family level, at a community level. And it's putting all these together that will really make an impact on improving the health of the population and reducing health inequalities. And I would now like to hand over to my colleague, Alla, who's going to talk to you a bit more about how we support our patients to live well. Thanks, Alla.
Thanks very much, Judith. Next slide, please. So before I get into the details of how we plan to support our patients, I just wanted to give you an idea of the scale of the problem. So there's 1 in 3 of us living with overweight or obesity in England as a whole, but as Judith mentioned, the number's even higher in North Central London, where it's just 1 in 2. There's 1 in 3 of us who are physically inactive, and that's not doing 150 minutes a week of recommended physical activity. And 1 in 4 of us drinking over the low-risk alcohol guidance of 14 units of alcohol a week. And still, 1 in 8 people smoke, and that number is slightly lower for vaping at 1 in 12 currently. So this isn't an issue that affects 1 or 2 people in a population. There are significant numbers of people and groups of people who are affected by this. Next slide, please. And they're not behaviors that tend to come alone. So people with a poor diet may also have quite an inactive lifestyle, and people who have excessive alcohol consumption, may also be smoking as well. And the important point about this is that every unhealthy lifestyle behavior doesn't just increase the risk that a person experiences, it multiplies it. And we know these risks aren't distributed equally across our population. We know certain groups, particularly from more disadvantaged backgrounds, are more likely to have these unhealthy behaviors, such as poor diet, excessive alcohol smoking, and an inactive lifestyle. And that multiplies the risk of them dying prematurely. Next slide, please. And that really gets defined in this term of health inequalities, which are unfair and avoidable differences in health across the population and between different groups within our society. Next slide, please. And Judith alluded to this earlier, but really this is what it looks like in practice across North Central London. If you are getting a bus across from Barnet on the left-hand side of those graphs, across to Edmonton and Enfield on the right-hand side, the people you meet at the end of your bus journey would be more likely to die between 11 and 12 years earlier than the people you would have met at the start of your bus journey. Next slide, please. And that's why we set up the Faculty of Population Health, because we know there's significant inequalities in life expectancy, so how long people will live, and healthy life expectancy, how many of those years they'll live in good health. We know the long-term conditions of cardiovascular disease, respiratory disease, and cancer are major contributors to these inequalities. And we know that smoking, alcohol, physical inactivity, and poor diet are modifiable behaviors that can lead to these long-term conditions. And as I mentioned, they are clustered in communities that suffer more disadvantage. But we also know that there's good evidence for lifestyle interventions. And the NHS is uniquely placed in that every 24 hours, we come into contact with over 1 million people at moments in their life that really bring home the personal impact of health. And this conversation can be really impactful. And we can't afford not to do it now. This saves lives where nearly a quarter of all deaths in North Central London could have been prevented or treated for those over 75. We can save significant amounts of money, thinking billions of pounds due to physical inactivity, smoking, alcohol misuse, and being overweight or obese. And this will inherently reduce the pressures on all healthcare organisations across North Central London by addressing this, and nicely fits in with our clinical strategy in line with that. Next slide, please. So our aim is pretty clear. We want to empower staff and patients to have conversations to live well, improve their health, and prioritise prevention. And as Judith mentioned, this is really a culture change programme focused on staff because they will have the impact on their patients, and that will spill over into our local population as well, of which they are a part of. Next slide, please. We're really keen to have a co-designed approach where we're conscious of being culturally sensitive, particularly as we welcome colleagues from the North Middlesex into our trust, be person-centred, but also pragmatic. It needs to be a cost-effective and sustainable programme to allow us to see it through. Next slide, please. And in essence, this really is a culture change program. We have an expectation of our staff, supporting our staff, as well as expectations of our patients and visitors. We want our patients to come in, not only address the health issue they came in with, but actually let them leave with the best chance at good health for the foreseeable future by addressing these modifiable health behaviours. And we need to do that by making sure staff are prescribing nicotine replacement therapies within 2 hours of admission to give each patient the best chance at stopping smoking on this hospital visit. We need to support our staff with the NHS Cycle to Work scheme to keep up their physical activity. And we need to have an expectation of patients and of visitors to take up these changes and maintain them over time. Next slide, please. Our 6 key objectives and how we intend to do this is firstly by training staff to have conversations confidently with patients about living well and improving their health. Supporting our initial pilot sites, which we'll show you in a minute who they are, to embed this approach into their clinical practice, upskilling our staff in population health and how to prioritize and embed prevention to improve patients' health, and making sure we have really clear signposted resources that are accessible for staff and where possible also improve access to community services directly. We're really keen to embed our tobacco dependency pathway and active hospital programme across the trust. And finally, we work really well with local, regional and national partners to embed prevention as business as usual in our organisation. Next slide, please. This is our structure and governance, and you'll see we have a faculty steering group that meets quarterly and 3 key task and finish groups, one focused on training and education, one focused on patient involvement and communication, and the third on our evaluation. Our current pilot sites, which we're rolling this out in our first year, include cancer, cardiovascular, renal, preoperative assessment, maternity and cardiology teams across all of our sites. Next slide, please. So I have a question for you now in the audience. How many attempts on average does it take to quit smoking? And if you pop a number in the chat for me, I'll give you a hint. It's between 1 and 10. Keen to see what ideas everyone has. I'll just wait for those numbers to get through. Take a wild guess. So between 1 and 10 roughly. Any ideas? I'll let you out of your misery. It takes between 6 to 7 attempts on average to quit smoking. The people who have the most impact in getting everyone to quit are friends and family, understandably. But straight after them, healthcare professionals are key to getting people to do a quit attempt at smoking and hopefully maintain it in the long term as well. Next slide, please. And this is the thought process that happens behind it. So there's lots of stages of change before a health behavior is changed. There's the pre-contemplation where it's an idea in the back of your mind, thinking about it more thoroughly in contemplation, preparing for that health behavior change, and then actioning it, and hopefully maintaining it, but sometimes also relapsing. What we intend to do with this program is really disrupt that cycle, because we know a health event in itself is quite triggering to rapidly shift someone from contemplation into action. And they're also more likely to maintain that action after a health event. Next slide, please. And this is an example of that. So Emily is a 58-year-old patient who came to our Royal Free Hospital. And she said she probably started smoking because of peer pressure when she was 13. Everyone else around me was smoking. All my friends were smokers, and it seemed like fun. I tried to stop smoking once before. I tried with inhalers and patches, but I didn't think my willpower was strong enough, so I gave up. And this is a message we hear again and again, is that most people who smoke want to give up smoking, but just need the help to do it. So she was then admitted for a pneumonia, and a sinister shadow was seen on her chest x-ray. So obviously quite a stressful time. Happy to say that thankfully it turned out to be nothing serious and she recovered really well from her pneumonia. But actually that hospital visit was the trigger for her to give up smoking once and for all. Next slide, please. And it's so lovely to hear this final message from her, that mentally I feel really proud of myself for achieving something that a lot of people couldn't. I have 72 steps up to my flat, and I can now get to the top of them without coughing my lungs up. Being a grandparent, I now don't feel bad about having family in my house, as the smell of smoke is no longer there. It's those achievements that make me proud of myself. Next slide, please. Not only does that have a great impact for patients, but also our staff feel really empowered through this messaging. So this is from our consultant in pain management, who said she saw a patient on the 18th of March for an injection and referred him on that day to smoking cessation, as she would do in her normal clinic. And he'd been smoking 20 a day for 30 years previously, so quite a significant smoker there. And he then told her he'd been contacted 2 days after the referral and hadn't smoked since. And she was overwhelmed and really proud of the achievement she'd had as a clinician in impacting that patient's health. Next slide, please. So this is how we plan to deliver it. Over the first year, we're working with our pilot sites to identify opportunities where we can train up our staff, develop bespoke training materials, expand our tobacco dependency advisor service and our active hospital program, and really thinking about collecting what the baseline data is and how we continue to evidence our improvement over time. In our second year, we're embedding healthy conversations into more and more pilot sites, developing our champions and facilitators, and taking a real quality improvement approach to our tobacco dependency service, as well as beginning active hospital program pilots and building a research plan. And finally, in our third year, ambition is to roll this out more broadly across the trust, really embedding it in a sustainable fashion through all the facets that we've mentioned so far. Next slide, please. To finish off, I just wanted to let you know about MechLink London. So if you're interested in hearing more about the services available locally in your borough for the topics we talked about around smoking, alcohol intake, physical activity or diet, or more broadly for other areas where there is local support, please have a scan of this QR code, and the link will also be in the chat where you can follow it up. Next slide, please. I'm now going to hand over to my colleague, Maria Goddard, who's our active hospital lead and a lifestyle physician, to tell us how this looks like in regards to physical activity as an active hospital.
Hi there and good evening. My name's Maria. I get to do the fun bit. I am a lifestyle physician. I've worked in the NHS for a very long time. I've always been frustrated about the lack of prevention. And in 2017, a new academic medical college opened up called the British School of Lifestyle Medicine. So I did my diploma and I'm up and running. Next slide. So just to have a look at the determinants of health, which we've already touched on, but when you normally come to the hospital, you're pitching up at the green end of this line with the problems that you have developed. And then we will, as very clever physicians, do all these tests and check your blood pressure and your sugar and your cholesterol and look very clever and tell you what to do about them. But in actual fact, what we have neglected for a long time and what we should be looking at and what we are beginning to look at now as physicians and lifestyle physicians is what is causing those problems in the first place. So we're really interested in all those lifestyle factors that cause you to become unwell, and they're all having the same basic trigger, and we all end up with what we call these non-communicable chronic diseases, 70% of which need not have happened. So as lifestyle physicians, we're looking in that middle area in those blue boxes to see what's going on. Next slide, please. And we generally say the 6 pillars of lifestyle medicine. You could probably add a few more as time goes on, but it's thinking about healthy nutrition, physical activity, which is what I'm particularly interested in. Sleep is hugely important, and we've neglected that for a long time. Stress, well-being, we know now that is as bad for you possibly as smoking. If you're under chronic stress, it is driving all the same triggers in your body that will be causing these non-communicable diseases of physiological changes that lead to disease. Obviously, your risky substances, your smoking and your alcohol and pollutants and all these novel chemicals we're being exposed to, hugely important. And relationships. Relationships are key. Bad relationships cause stress, which can lead to illness. Next slide, please. So just looking at London in particular, the top 15 risk factors for early death are as on the chart there, tobacco being the biggest one, as you just mentioned, high blood pressure, diabetes, poor diet. And if you look carefully at those, the ones in green are the ones that can be positively affected by increasing our physical activity. And this is what I'm particularly interested in, because if about a third of us are inactive, that means we're doing less than 30 minutes of physical activity a week. And that has a huge strain on our biological systems, because we're essentially made to move. Our biology needs us to move for it to work properly. Next slide. I think we're moving on to our video here, not quite. So I am part of something called Moving Medicine, which has been dubbed the single most important advance in medicine for 50 years by Professor Sir Muir Gray in Oxford. And it was set up by the Office of Health Improvement and Disparity in Sport England to try and bring more movement, more exercise, and more awareness of how important movement is for us into all our hospital systems and our patient pathways, into every clinical contact, to make every contact count, into our medical education, and importantly into our community links, and to go outside the hospital into the community and deliver that education. Next. So this is a video from the Canadian government, which we're going to watch. It's very short. It just gives you an idea of what it's all about.
What will your last 10 years look like? Will you be quick enough for a game of tag with your grandchild? Strong enough to embrace every moment? Will you grow old with vitality? Or get old with disease? It's time to decide.
Thank you. So it's quite a hard-hitting video, but it gives you an idea how being physically active can really improve your long-term health outcomes. And that's hugely important if we're looking at resourcing our healthcare system and our care system as we all get older and become more unwell, as we're predicted to be. Next slide, please. So what should we be doing? And Ala's already said it's 150 minutes of physical activity a week, and that does not need to be exercise in the gym. It can be doing lots of different things, gardening, walking, looking after the grandchildren. But I think the most important thing for us to think about now, because there's a lot of emergent scientific evidence, and we've got to be thinking about muscles. We've got to be thinking about muscle strength. We have got to be thinking in terms of a little bit of vanity, and apparently vanity is a great asset when it comes to your health, because we all like to look good, and looking good is helped by physical activity, in particular looking after your muscles and looking after your body. Balance is really important as well, and also minimizing our sedentary time. So far too much time sitting on computers, watching television. It's really bad for us. We're not made to do that. We are made to get up and move, and we should be doing that at least every 30 minutes. We'll be doing some of that shortly. But thinking about muscles in particular, I think this is really important for us all, particularly as we get older. Young people are doing it anyway. They're all going to the gyms. They're all looking buff. It's really good for your health, and I'm about to tell you why. So moving on. So what does physical activity actually do for us in health terms, and what could it do for us in the NHS? It's got huge positive impact on reducing these long-term diseases that we've been talking about, and for mental health, which is extremely important at the moment. We're under also a tsunami of mental unhealth. So it can reduce your chances of dementia by 30%. And a lot of people would argue that actually it's much more than 30 now. Depression, 30%, anxiety and depression. And the Royal College of Psychiatrists are now advising physical activity and good nutrition as a first-line treatment for anxiety and depression. Hold off with the tablets. Try these things first. Reduction of breast cancer from developing, 20%. And as Judith said, if you have a diagnosis of breast cancer, if you're physically active, you can reduce your mortality risk by 40%. I mean, huge, very exciting statistics here, not for us all individually, but for the NHS. And colon cancer, which is on the increase, that you can reduce your risk by 30%, diabetes 40%, cardiovascular disease by a third, and your all-cause mortality basically by a third if you're physically active. And do your at least 150 minutes a week, but also thinking about your muscles. Muscles are really important. Next slide. So this is why the muscles are really important. They're not just about keeping us upright and moving us around. They're actually an endocrine organ, and that means they are producing important proteins and substances when we're moving them that are doing incredible things to the rest of you. And this makes perfect sense because we're essentially still hunter-gatherers. Our muscles are keeping us fit and healthy. So when we exercise, we are producing factors from our muscles, which then course through our bloodstreams. They're getting up into our brain, they're getting to our bones, to our tendons, to our joints, to all our gastrointestinal organs, and restoring and repairing those organs. And that is why exercise is so powerful. There is actually fantastic evidence now about what is actually happening, what your muscles are producing to have this amazing impact on your health. And there's now, I think, about 16 types of cancer that have been to be effectively reduced by exercise. And it's because of all this endocrine activity. And this is really under a huge amount of study at the moment, and it's a space worth watching. And these chemicals, these proteins, we're calling them myokines, which just basically means they're proteins produced by muscles, myokines. Next slide. So until somebody can distill all those myokines and put them in a little pill and we can take one every day, it would certainly be a wonder drug. We are going to have to do the activity, but this is a very powerful picture, I think, and it's really true. It is the best thing we have. If we only had one thing to fight disease, it would be exercise. Next slide, please. And the most important thing to remember is if you're not active, don't panic, because the people who benefit the most are the people who go from doing nothing to doing something. So ideally, we do about 150 minutes minimum a week, but actually you can see from this curve, if you're going from sedentary, hardly moving at all, and that's not so difficult to do if you're driving and you have a sedentary job, that if you go from doing 10 minutes of exercise a week to 30 minutes or 60 minutes a week, you go up the graph very swiftly to getting a really good response to the dose of exercise that you do. Next slide. And really, it's about taking care of yourself. And this is a beautiful slide. It's about strength and balance, but it could be mental resilience. It could be cardiovascular health. You could put just about anything on that y-axis. And if we have a healthy, younger life, We don't all, but if we do, as you see, we go up on that green line and we will go into adult life being fit and healthy and well. And of course, as we get older, things do tend to fall off just a little bit. We are destined to get old and to die, but we can keep ourselves above what we call the disability threshold if we look after our bodies and we keep active and we do all the right things. As we get older, even as things begin to get worse, we will still be self-caring, we'll still be independent, we'll still be cognizant, and we won't need care, which is what we all want for ourselves and our family. But if you start off badly, if you have a bad start or things happen to your adult life and you don't look after your body, then you will gradually deteriorate. So it means when you hit sort of mid to later adult life, then you start to run into real problems and you need medical input and ultimately you need care. Next slide. So what I would like to do, I would like to condition the country. That would prevent 1 in 6 premature deaths. It would save the NHS £7.4 billion every year, and we could have a whole lot of fun doing it. And we really need to change our culture from as we're getting older, doing less, taking it easy. We actually have to do more. We have to get out there, move our bodies and enjoy ourselves. And just to prove that we walk the walk and talk the talk, we are going to do a little bit of movement. So if you're sitting down at home, you can stand up if you want to. Please don't do this if you have any injuries or you're not feeling great, but we're going to have a little bit of movement. So we're going to have a video, and if you just follow the movements in the video and think of all these fantastic myokines that will be pumping around your system, making you healthier.
All right, this was nice and fun. We had fun putting it together. I have Nishi and Kiera with me. Let's go. Tap. Clap, clap. Open. Good. All right, we're gonna keep the hands the same. We're gonna change the feet. Take it out. 4. Good, good. Open. All right, we're gonna have us change here. Rock. Good. Up, then down. Rock. Up, down. Shine. Good, nice and smooth. Rock it out. And up. We're gonna start from the top. Good. Once again, we're going to change that leg motion to open and close. Open. Good. Nice and strong. All right. We're going to rock it out. Take it up. Up and down. Rock. Good. Shine. Rock it out. Up. We're going to have a change here. Roll it over. Good. Roll. Shine. Rock it out. Good. Here we go. Stop it. Pep. Stop that foot. Keep it going. All right, we're going to have that gentle sway from the top. Good. Nice and easy. We're going to let it shine up and over. 4, 3. Back to the hook. Rock it out. And up and down. Good. Shine it out. Rock it out. Roll it over. Good. 2 more. Shine. Rock it out. Woo! Awesome. Hey,
Oh, that's great. I really enjoyed that. I hope you. Oops. Am I back on? That is
you're
really
back on.
great. I hope you enjoyed that. I love my job. Such good fun. It's really important to bring a bit of fun into your job, I think. So that brings us to the end of our presentations, and I hope you really enjoyed them. If you want to find out more about population health at the Royal Free, it's in the annual report, and you can find it on the website. I think the link has been shared in the chat. And if you have any other questions for us, you can email us, and our email should also be in the chat. And now I'm going to hand back to Judith for questions.
Thank you very much, Maria, and thanks for guiding us into our chair dancing. It's become a bit of our thing, and lots of people have heard us in our team meetings to go, I don't know what you're doing, but can I join your team? And that's what we're doing. We walk the talk, and love it. It's a lot of fun. So this is a chance for you to ask some questions, and hopefully we'll provide some answers. There were a few that were submitted in advance, so I'm going to read the question out, and we'll start answering them. So I'm going to start. Alla, this one's for you. How will you measure the success of your population health initiatives? And Maria, just a heads up, you're next after this, and then I'll answer one. Okay, Alla, over to you.
I'll focus maybe on talking us through the Faculty of Population Health, which is the work I'm most involved in. And really, I think there's 2 parts to this. There's firstly, we need to understand where our current situation is to identify where we really want to go. And that's really getting our baseline and building up that data as we go through. And then obviously there's the actual data we want to collect. So as I sort of alluded to in my presentation, the 3 groupings that we want to collate data on are our staff, our patients, and us as a trust. So thinking that due to the fact that it's really a culture change program where we're so focused in on empowering our staff, what we want to do is understand, have we allowed staff to make this part of their role? Have we provided them with the knowledge and skills to be able to do this effectively? And actually, has this had an impact on them specifically? Have they been able to improve their health and well-being through this program as well? Thinking about our patients, how we plan to evidence this is thinking about the population health improvement. So are they improving, are we improving the number of people doing physical activity, like that lovely example, improved diet, and how does that track over time? But also a second component of that that's really important to us is improving the quality of the data. So it's really important for us to know how many people are smoking to be able to target and deliver that service to them and track how that improves over time as well. And then finally, thinking about it from a trust perspective, we're really keen to change that organizational culture. So is this evident in our policies? Is this evident in our senior leadership? And we do feel that there's a strong economics argument around this as well. And there's significant return on investment we can prove in a year. And actually getting that economic data and modeling it is a key part of our evaluation as well.
Lovely, thank you, Alla. Maria, this question is, I think, got your name on it. Someone wrote in and said, can lifestyle medicine help reduce your risk of developing all diseases associated with aging, or are there certain ones that are inevitable? Thank you.
Obviously, yes, definitely, it can reduce your risk of aging. It reduces your frailty. It reduces your biological age. So we're all sort of growing up and adding on numbers as we get older, but there's a huge difference between your chronological age, that's the age you actually are, and your biological age, and that's obviously how healthy you are. So you could have a group of 160-year-olds, but some would be biologically 40 and some would be biologically 75, and that is dependent on lifestyle. So all those 6 pillars, the nutrition, the activity, the stress, the sleep. But importantly as well is our perception of ourselves, how we age. If we perceive ourselves as getting old and frail, that actually makes us get older and frailer. If we perceive ourselves as young and active and fit, we actually live for longer. So very interesting stuff. So and it's about changing our culture also as we get older. Aging is inevitable, frailty is not, and the illness, the blanket of illness that we accept as part of aging needs to be ripped off. There are obviously a lot of diseases that we may well get, and our chances go up as we get older of getting them, and a lot of those are unavoidable. But lifestyle is hugely important for healthy aging and our approach to aging. So we need a huge culture change in our approach to aging.
Many thanks, Maria. I love that phrase. Aging is inevitable, frailty is not. I really live by that one. So another question that came in advance was, how can technology be used to enhance population health initiatives? And I'm all about trying to make what we talk about real and tangible. So I'm just going to think about my own cancer journey and what technology I used through that journey. I'm a patient at the Royal Free, so I use the patient portal, which I think is a fantastic bit of technology. It's really helped me know when my appointments are and what my results are and so on. My data is all put up on the electronic patient record. I was determined to really make sure I was on top of my lifestyle for all the reasons that we've outlined tonight. And so I wear a wearable, and I have an app, and I tracked what I do, and that's really helped me make sure I'm on top of everything. And in fact, it does part of that tells me what my biological age is. And since my cancer diagnosis last year, my biological age has reduced 10 years. So, I mean, there is nothing like having a cancer diagnosis, in my opinion, to make you very motivated to watch what you're doing. And I thought I was pretty active. I thought I was eating a pretty healthy diet, but I've made some significant changes on a daily basis, and I'm highly, highly motivated. I still intend to live to 100 and to live very, very well to 100 with a good quality of life. Yes, I've reduced my age by 10 years according to my wearable. And then there are other apps. So we have the NHS app, which we really got to use during COVID in terms of the vaccines. But there are other apps available. You say NHS uses. There are weight loss apps and diabetes apps, for example, very specific ones. And then we've got the whole use of the virtual world. So now we have virtual wards at the hospital. We have virtual outpatients, virtual consultations. We do that both with our GPs and at the hospital. And something that we're talking about, thinking about a lot more now, is the use of AI, artificial intelligence, ultimately. And so thinking about how can we really embed prevention and really develop that personalized approach so we can do some good prediction and use AI. And this is very much a work in progress, but part of my treatment was the use of genomic testing. I had to look it up when they mentioned it to me, I confess, but this was looking at my personal genetic material to then say have this treatment. Extraordinary personalized care. So this is another new technology that I've absolutely benefited from. And then we also use AI currently in terms of some of the mass screening that we do. So looking at mammograms, looking at eyes, so I think, technology is very forward moving. It's a very exciting time. We're using technology at population level with the mass screening. We're using it at trust level, organizational level, but also able to use the to do things at a personal. Whoever sent that one in. I can see that there's a question come in here. What about the role of primary care, given that most patients see GPs more than hospital clinicians, and the medical model in primary care is prescription rather than prevention? How can you change this? Alla, would you like to answer that question?
Yeah,
Thanks.
sure. So I think to start off with, it shouldn't be either or. I think we all really work together as a system well, and that's how we can have the most impact. And primary care does do a lot of fantastic work around prevention, thinking about all the screening programs, all those vaccinations that they provide, and they get through to lots of groups in the community that maybe we wouldn't be as adapt to accessing from hospital. But actually, I think I'd like to flip this question on the head and think about what health really is. And we know from the World Health Organization definition, actually, it's predicted that only 20% of good health comes from clinical care. That's seeing that patient seeing a doctor or healthcare professional. We know another 30% of health comes from the behaviors, the health behaviors we've talked about today around smoking, alcohol, physical activity, and nutrition. And there's this big 50% of health that really comes from what can only be described as life. That's the housing you're living in, and if you have damp problems that lead to respiratory issues and mold. That's thinking about the education and job, and whether that job allows you to take the time to look after your health. Can you attend an appointment, or are you on a 0 hours contract that you just can't sacrifice that appointment slot? Does it give you the income to be able to do activities that help and maintain good health? Do you have that social network and those relationships that allow you to promote and prioritize your health? And really, a lot of those bigger life pictures are actually impacted much more by our local authorities and national government policy. And a classic example of this is the smoking ban indoors, where we saw just a curtailing of smoking and the number of people smoking dropping. So I think really coming back to the question, my response would be we need to do prevention at every layer, and we need to work as a system to do it. And that's a lot of changes in the NHS in the last 10 to 20 years have really been pushing towards that, working in the different parts of the NHS to actually embed prevention, making sure we're getting people in the best health we can, rather than when they get unwell, dealing with it as a sickness service.
May I just add something?
Go for it, Mo.
I'm going to just say that actually there are tens of thousands of healthcare workers now being trained in lifestyle medicine out there in the community. And as a tsunami of ill health comes one way, there is a tsunami of lifestyle trained clinicians and healthcare professionals coming the other way. So you will come across this more and more.
Thank you very much. I'm conscious that I now need to hand over to Sneha to wrap up, but I've just seen the one question that talks about people smoking outside the hospital. And can I just say that we are addressing this in a multitude of ways, and I hope that you will see a significant difference in the near future. So watch this space. And now it's time for me to say thank you very much for inviting us along, and over to you, Sneha. Thank you.
Great. Thank you so much, team, for taking us through this. It was brilliant. And I loved your, Judith, thank you for sharing your personal story and journey. And the chair exercise was brilliant, even I was doing in the background. So thank you. I think little bits make a big difference. Thank you so much. And also on behalf of the Council of Governors and everybody who has joined, thank you to the team again. I think this is a very, very important topic considering the direction of travel NHS is taking, and how not only NHS's responsibility to provide primary care, but as an individual, our responsibility to look after ourselves and contribute to our community by taking care after ourselves a lot more. I think that's the contribution. If we all make a bit of it, we'll make a big difference as membership and as well as the common person within the community. So I hope people take something from this session and as a responsibility to make a small, slight, different change in their lives. And one of the things I would also like to say during the Q&A, if we've missed your question, or if you still want to ask us any questions after the session, please do email it to the membership inbox, and we'll be more than happy to answer those questions for you. This is our last Medicine for Members events for 2024. I hope you enjoyed the program this year. If you have missed the previous year's recording, it is on our website. And also for 2025, we are looking to create this program again for 2025. So if you have any topics that you would want us to cover, please do share with us on the membership email, and also a feedback form would be sent out after this event to make sure we've captured any insights that you might have. And also, once again, if you want to contact Council of Governors, you can email us. The email is being shared on the screen as we speak. Once again, thank you for joining us, and I hope you enjoy the rest of the evening. A big thank you to the team. This is really insightful. Thanks a lot.